My name is Martino Maggetti. I'm a professor of political science at the University of Lausanne, and I am the coordinator of the TiGRE project together with Yannis Papadopoulos. I would also like to thank very much David Levi, who is the main organizer of this webinar series. We had the first talk last week, which was very successful. I guess you are invited to log in, to visit our website. And today is a pleasure and an honor to welcome our keynote speakers, Koen Verhoest, Sophie of the Beeck, and Monika Glavina. Sorry if my pronunciation is not perfect. Koen is a research professor in public governance at the University of Antwerp. He is the author of many influential publications, especially on agency autonomy, coordination, collaboration, regulatory governance, more in general, and I would say more recently on the trust in public governance. In addition to TiGRE, which is our project on trust in regulatory regimes, Koen has been involved in several large and I would say very well-known research projects like COBRA on the autonomy of agency, Tropico on the digital transformation and collaboration, PSICO on innovation through collaboration, and is also the coordinator of the GovTrust Center of Excellence, which is a multidisciplinary center focusing on trust and distrust in multi-level governance. Sophie of the Beeck is a research manager for GovTrust and has been involved over the years in several important research projects in the field of public governance. And Monika Glavina is a research assistant and a PhD candidate at KU Leuven. You may want to add something to your biography if you wish. I think that we can aim for a 30 minutes or so presentation. Is that correct? And then we will have an open discussion. So you can write in the chat if you have a question, or you can also write the question directly in the chat. And then I will give you the microphone just after the keynote speech. Okay, so thank you very much. The floor is yours.
Okay, thank you very much. I will share the screen. That should be okay. Okay. Do you see the slides?
Yes, we do, but we see the third one, not the first one.
Okay. This is the first one. Okay. Thank you very much for being present. We will try to keep the presentation to 30 minutes, might be a bit more. But thank you very much, Martino, for the excellent introduction. You make me blush with all the things that has been said. What we will do today is basically, it's much more focused, or at least much more applied than last week, the seminar of last week, which were really fundamental discussions. This is about the link between trust and vaccination. It's building upon a paper that we wrote together with people from the Center for Evaluation of Vaccination and the Vaccine and Infectious Disease Institute at the University of Antwerp, which are Pierre van Dam and Greet Hendricks, who are well known in the field of vaccinology. What we will discuss, so Sophie and I will share the presentation. First, we will discuss, of course, what vaccine hesitancy means, how it relates. In the second part, we will bring in trust and how trust affects the vaccination decision for well-known diseases. And then in part 3, we focus more on the relevance of trust for vaccination hesitancy when we have a health crisis like the swine flu or Ebola. And then we move in part 4 to what we know already or what is emerging in terms of insights about trust and vaccination in the coronavirus crisis. And there we will also build upon the analysis we did in a recent paper with the two colleagues from vaccinology. And then we will come to some conclusions. I hope this brings an interesting story. I give the floor to Sophie.
Thank you, Koen. So let's start off with a little background on vaccination and the concept of vaccination hesitancy. So vaccination is considered to be one of the greatest achievements of public health. Koen, can you switch the slide? During the 20th century, mass vaccinations programs have resulted in dramatic declines of the incidence and also the mortality of various infectious diseases, for example, smallpox or polio. And what we see is that vaccination prevents, of course, disease in the vaccinated individuals, but also it protects unvaccinated individuals in the community when certain proportions of the populations are vaccinated. And this is known as a phenomenon called herd immunity. Now, the big advantage, of course, of vaccinations is that the World Health Organization estimates that vaccinations prevent about 2 to 3 million deaths every year. But apart from these public health benefits, there are also some economic and societal benefits from vaccination. For example, by saving costs in potential healthcare spending, or by avoiding indirect productivity losses from employees falling ill. Now, for vaccines and vaccination programs to be successful, of course, it's crucial that there is a high uptake level of vaccines and in order to create this herd immunity. And today, these uptake levels are often still under the targets set by the World Health Organization. So efforts are being made to increase vaccination uptake, but these are being undermined by a growing anti-vaccination movement, which challenges the legitimacy, the safety, and the necessity as well of vaccines. And this, of course, results in a growing concerns among the mainstream population and continues to undermine immunization campaigns worldwide. Now, these doubts, the former slides, are coined as vaccine hesitancy in the literature. And what important to mention here is that vaccine hesitancy is a vaccine-specific attitude. So, for example, hesitant individuals may refuse some vaccines but agree to others. So, and that's why today vaccine hesitancy has become a major public health issue. And according to the World Health Organization, it's one of the top 10 threats to global health. Now, there have been several models that are developed to understand vaccine hesitancy. We will discuss two of them today. One of them is the 3 C's model, the complacency, convenience, and confidence model, which was highlighted by the World Health Organization in their strategic group of experts on vaccination as well. And in this model, complacency refers to the perception that risks of vaccine-preventable diseases are low and that vaccination is not deemed a necessary preventive action. Convenience refers to the extent to which vaccines are available, affordable, accessible, and also understandable to the population. And then confidence refers to trust in the effectiveness of the vaccine, but also trust in the system that delivers them and trust in the policymakers that make decisions. Now, each of these 3 C's require different types of interventions to reduce vaccine hesitancy. For example, convenience issues may call for strategies such as enhancing geographic access or reducing costs. But then on the other hand, confidence issues may require education or support on vaccination. A second, more elaborate model is this conceptual model from Beeck and colleagues, and consists of 3 domains of factors that influence an individual's decision on vaccination. The first domain on the left is public health and vaccine policies. Of course, policymakers are the ones who develop vaccination programs, so they are quite important here. Second, on the right of the figure, you can see health professionals who play an important role in providing vaccines, but also in their relationship with patients. Third, at the bottom, we see that communication and media are important in diffusing information on vaccination, and it includes both traditional media, of course, and also internet and social media. And finally, then, at the top, you find the category on the context, because all vaccination decisions should always be considered within the historic, political, and socio-cultural context, which of course refers to issues such as people's past experiences with vaccination, religious convictions, or certain social pressures that they experience. Now, a final aspect I want to highlight in this model is the role of trust that is stressed, particularly trust placed in public policymakers, in health professionals, and in the media that conveys the information on vaccination. Now, as already apparent from the previous model, trust plays a key role in a people's vaccination decision. So let's look a bit closer into this role of trust. First of all, let's look into the concept of trust itself in general. So we see that trust has been studied in many different academic disciplines and has resulted in many different definitions. The one we present here by Rousseau and colleagues is a widely accepted definition, but generally important to know is that trust is refers to someone's intention to accept vulnerability under the condition of risk and uncertainty. So trust is also considered a relational concept where truster X trusts trustee Y to do Z. And in this trusting, they find in the literature that there are three steps in the process. So the trust process consists of an assessment of trustworthiness, the actual decision to trust, and then trust-informed actions that follow from that. Now, the assessment of trustworthiness is based on expectations from the trustor towards the trustee on their ability, the benevolence, and integrity. And to also assess such trustworthiness, trusters use several sources of evidence. For example, their previous interaction between the trustor and the trustee. Also institutions such as formal rules, informal routines, and social norms that shape someone's expectations towards the trustee. And finally, people also have an individual predisposition or propensity to trust. Now, if we then look into the relation between trust and vaccination, this is nicely visualized by Larsson and colleagues from the Vaccine Confidence Project. And overall, the idea of this model is that the vaccination decision is influenced by trust factors that are either related to the vaccination as well as external trust factors. So the vaccine-related trust factors are shown in the triangle, and they include product trust, which of course refers to the vaccine itself, provider trust, referring to health professionals mainly, and also trust in policymakers. In addition, there are also these three external factors that influence trust, which is generalized trust, the general propensity to trust from someone, historical trust based on, for example, past health system performance, and also influences from outside the health system, such as friends and family, or even religious leaders, or even celebrities. So next, let me say a bit more on these different elements from the triangle. And the first element is then product trust, trust in the vaccine, where we see that most issues on vaccine confidence can be traced back to concerns and doubts on the safety, the effectiveness, and the importance of vaccines. And mainly safety concerns are an important reason for vaccine hesitancy. And people's perception of such safety of a vaccine is determined by the quality control issues, speed of development, potential side effects, but also controversies on vaccination. We see, for example, right now with the development of a new COVID-19 vaccine that the accelerated pace of vaccine development may heighten people's concerns. Now, from recent numbers, we see that there's still a long way to go, and a 2018 study on vaccine confidence in the EU has shown that the EU has among the lowest confidence in the safety and effectiveness of vaccines worldwide. And yeah, another visual of this vaccine confidence and how it has evolved throughout the years. It's shown here in the world maps. It shows the variation, in fact, in the levels of vaccine confidence around the world. On the left side, we see the situation from 2015. And on the right side, we see the situation from 2018, where we see that confidence in the importance and effectiveness and the safety of vaccines has decreased significantly, for example, in some Asian countries, but has also increased in some EU countries, for example. So it's not a constant, it's quite continuously changing the way people think about vaccination. So the second vaccine-related trust factor was trust in healthcare professionals or in scientific experts. What we know from the literature is that healthcare professionals are generally the most trusted source of information on vaccination, and they convey their trust through their knowledge about vaccination, their attitude towards vaccination and how they approach their relationship with their patients, of course, and also the way they communicate about vaccination. Another important issue to mention here is the crisis of confidence in science. In fact, there's a rising skepticism towards science, which also may shape negative attitudes towards vaccination. We see, for example, that the skepticism results from balkanization of scientific knowledge, with a multitude of scientific results that are often partial, provisional, or sometimes even contradictory. And denialists, of course, they make use of this balkanization and put forward sometimes even fake experts to discredit the work of established scientists. And then a third and final element in the vaccine-related trust model is the trust in government and policymakers. So governments and policymakers their role is actually particularly relevant because they regulate and sometimes even mandate vaccination programs. Now, overall studies find a positive association between trust in government and vaccine uptake, but trust in government can be manifested in different ways. We see, for example, that people look at trust in information that they receive from government or trust in government's technical skills, but also people who do not trust the government in general, whether it's about vaccination or other issues. They may extend their general distrust of government to distrust in vaccination as well. And then if we look at some of the evidence from the effect of trust on vaccination from the literature, we find a more general positive relation between trust and vaccine acceptance. A literature review recently done in 2018 by Larsson and colleague found that studies tend to agree that various kinds of trust can be associated with vaccine uptake. And interesting to mention here as well that vaccines such as measles or HPV, which are administered to children, particularly look at parental trust and the trust of parents in information sources and how that shapes vaccine hesitancy among parents. An interesting study here to add here is the Scherer et al. They find that information is good, but for trust building, but too much information may also reduce trust at some point in time.
Okay, thank you very much. I will now move on with part 3. And part 3 basically makes the argument that the role of trust in a vaccine and reducing vaccine hesitancy is even more important when it comes to times of crisis. A health crisis like a pandemic with an unknown disease is basically something new and forces society, but also governments to think about the crisis management strategy. And in that crisis management strategy, they basically try to control spread of the disease, but also try to learn about the disease, how it evolves, and regulate the finding a therapy, but also a vaccine. And vaccination is often seen, and certainly now in the COVID-19 crisis, as some kind of cornerstone, the ultimate solution for solving the crisis and bringing back societies to their normal functioning by creating herd immunity. But of course, both the other measures like social distancing, lockdown, but also vaccination, will only bring their results when it's sufficiently complied with by citizens and by members of society. So certainly in crisis times, vaccination as well as other protective measures become very much an issue of compliance. Because also the fact that there's an enormous pressure to develop and implement a vaccine in a very high uncertain circumstances builds upon this element of urgency and makes also trust more important, because people are actually looking at government to regulate this well and to make sure the vaccine is safe. So trustworthiness of government and scientific experts is particularly important in times of crisis. When it comes to the broader relation between trust and compliance with rules or recommendations by government, we can refer to a more or less agreement in the literature that trust is important, trust in government is important to induce compliance. And we see here certain fields where this applies and studies which support this. This will be discussed more in depth by Friederike Six in a few sessions, because she will discuss about the more refined relationship between trust and compliance. If you now look at what we can learn from previous crises, like the swine flu crisis, I will highlight a few studies because I think they bring in relevant elements. Or there are many more studies, but they make the point here. We have the study by Tom van de Weert, who actually studies the swine flu pandemic in the Netherlands. And basically, he measures trust in government by one measure, which is composed of trust in government in general, so institutional trust beyond crisis times, and crisis-related trust in government, in the information they provide, and the measurements and the decisiveness they show in tackling the swine flu crisis. But it's together in one measurement. And this one measurement shows a positive relation with the intentions to adopt protective measures, but also the intention to accept vaccination. Important also is that other factors play a role, the extent to which people fear to get vaccinated, the vulnerability they have to get vaccinated, age and education. The older you are and the higher educated you are more inclined to agree with vaccination. Another study which is interesting is the study by Mesh and Surian from 2015, again focusing on the pandemic in the US. And there, what they measure on trust is the crisis-related dimensions. They measure trust in government by looking at the trust that in the government's ability to deal with the swine flu outbreak. Again, they find a positive effect. What is also interesting in their paper is that they show that political partisanship plays a role, with Democrats being more willing to agree with vaccination than Republicans. And that is also confirming a study by Baumgartner et al., which actually shows the effect of ideology, a direct effect and an indirect effect through trust on vaccination hesitancy. Again, there are other positive significant factors. A third and last study that I will present here in terms of learning from previous crises is the Ebola study by Beeck et al. And actually what they do is to split up a measurement of generalized trust. No, not generalized trust, that's wrong, but trust in government in general. So local trust, city authorities, provincial authorities, national authorities. So beyond the crisis times, and then the crisis-related trust in providing a good answer to the Ebola disease. And they see that both these elements play a positive role in accepting Ebola vaccines. So what we learn from these studies is that trust is important in the public acceptance of vaccination and health and crisis times, but it's both the general trust that people have in government overall beyond crisis times and the crisis-related trust, so how they are handling the crisis at that moment. Also, trust in information sources play a role, but again, we see here studies which actually show that sometimes the effect of trust in public information sources might not always be positive. And there are other relevant studies or relevant factors coming into play, like risk perception, vulnerability, political partisanship, age, and education. If you now turn to Corona, which is of course of most interest to us, what do we actually know by now? This is probably unnecessary. So it's a pandemic. Here we see the figures of the US, you see the figures of Europe, different countries, a second peak in autumn. And you see here the lower graph is Belgium, which is the worst pupil in Europe, as I say, with different peaks, but also with different very drastic measures like a lockdown, night curfew, of course, social distancing and reducing unnecessary travels. Of course, in the current crisis, the compliance to protected behaviors is very important. And if you look to the studies which do not necessarily to look to vaccination decision, but more to compliance to measures in general, we see already several studies which show that trust in government plays a role. There are studies who show that certain roles in government play a role, like trust in the governor or trust in the country president in compliance with protective measures against COVID. There is also in Denmark the proof that higher institutional trust creates compliance. Also in Italy, higher trusting regions, which also refers to social trust, plays a role in compliance. And then lastly, there are also studies showing that trust in experts and in science predicts compliance with COVID prevention measures. But what do we know about vaccination or vaccine hesitancy and how trust matters in the corona crisis? So as said, the vaccination is seen as the cornerstone of the crisis management strategy in most countries. But the vaccines are still under development. So it's basically asking about hypothetical vaccines, although we are now quite far in its development. And we see several studies already showing that vaccine hesitancy is a major problem, like 7% not wanting to get vaccinated and 20% being unsure in a multi-country study by Noman and Boyne and others. But what do we know about the role of trust in vaccination decision? There's the study of Lazarus, which has been published very recently, and they show that in a study of 19 countries that trust in government and trust in government information has a positive effect. I will briefly discuss results that we have from a recent paper together with Van Damme, Pepermans and Hendricks. And that builds upon a sample of 20,000 observations. And it's part of the Beeck Corona survey at the University of Antwerp, which is actually a weekly and from summer a 2-weekly survey measuring different health-related issues and trust-related issues in the Belgian population. We use the sample of the Flanders response because it's most encompassing. And what we actually studied are the following things. We brought in as two core variables, trust in government, but crisis-related trust, so the trust to deal with the COVID-19 crisis in a good way. And in a good way was actually deliberately called as such in order to allow people to choose whether they would value ability more, integrity, or benevolence more. And we take together the federal, regional, and local government in one factor. There's trust in scientific experts to know what the best measures are to tackle the crisis. We have measures of risk perception, being risk proximity, severity, and vulnerability. And we also include pro-socialness, which is basically the attitude that people have to do things for the benefit of others, even if there are disadvantages for themselves. And we link this to the intention to get vaccinated, and the way we actually measure the item for a vaccination hesitancy is formulated in such a way that it reduces the prevalence of other factors which are related to complacency and convenience. Is basically when there is a vaccine which is said to be safe and effective, and it's freely offered and demonstrated in your place of residence, would you get vaccinated? It's a 5-point scale, and we cluster the results in 3 values: certainly yes, certainly no, and the middle category, which is from maybe yes to maybe no, encompassing. So what are the results? I will not go into the graphs as such. We might discuss it in the discussion, but basically what we see is that both trust in experts and trust in government matters, so crisis-related trust. But we see, and that is what you actually see here on the figure, is that the trust in experts has a larger effect compared to trust in government. We do the analysis for 3 values. It's a generalized ordered logic model for certainly, maybe, and certainly not. And for the certainly not, we see that trust has a very small effects. It still has an effect, a negative effect, but it's extremely small. So it means that the group who are answering that they would refuse the vaccine are probably triggered by other variables than those in our model. For example, religious beliefs, which are seen to be important in other studies. Another thing which is probably important to say is that the effect of trust on vaccination intention is not different if you compare different subgroups, like young people versus old people, low versus high educated, low versus high risk perception. So the effect stays the same, the magnitude of the effect of trust on vaccination intention. And there's a positive effect of risk severity, vulnerability, and prosocialness on the decision to get vaccinated. So we will now conclude. It's of course a long story, and basically the key takeaways are that which we have said repetitively throughout the presentation, is that trust seems to be very important to understand vaccination hesitancy. It has different forms: product trust, provider trust, trust in political system, also generalized trust. But trust is not the only factor. When we look at vaccination in times of crisis, it surely becomes even more than in normal times a question of compliance. And then we need to take into account the institutional trust in government in general, but also the trust in government crisis specific to handle that crisis. Trust in experts and care professionals is very important, and probably more important than trust in government. The role of trusted information is important, and there are other variables like the ones we listed here: risk perception, political partisanship, pro-social values, besides trust between members of society, age, education, and religion. As such, this of course calls for, the whole presentation calls for an interdisciplinary approach to vaccine hesitant studies, which are already often done, combining knowledge from health science, political and policy science, regulatory governance, communication science, behavioral science and psychology, and other regimes. We can discuss later how to actually deal with vaccination hesitancy, but I suggest that we leave it now to this. Okay.
Great. Thank you very much. Extremely interesting presentation. We can move to the Q&A session and to the discussion part of this webinar. I have a number of questions / comments on the chat. I'm going to give the microphone to participants on the order the comments were written. Koen, would you and Sophie, would you prefer to get 2 or 3 questions, or would you prefer to reply to each question after another? Otherwise, we can so to say take 2 or 3 questions at the same time and give a consolidate answer. Mm-hmm. Okay, so we will proceed this way. So I will give first the microphone to Nancy.
Thanks for that. And actually, I have a different question than the one I put in the chat, although I'm interested in that question too. And it's based on your actual study. I'm wondering if you were able to do any breakdowns by race and ethnicity in terms of trustworthiness and or neighborhood. And I'm asking for a very specific reason. I am part of a racial equity council in the city and county of Denver, United States. And we know that there are strong neighborhood effects, which get back to the earliest slides that talked about people's experience with government influences their expectations and trust. And so I'm wondering if you have any capacity to break things down a little bit more that would disentangle people's experiences with government and their trust. Thanks.
All right. So I'm taking another couple of questions, or would you prefer to come back immediately on this one?
Yeah, if you prefer that I answer it immediately. Yeah. So what we can't do with our data is to see like somebody's origin or the second generation of another origin, not with our data, but I know, and that's an interesting study by Gustavo Mesh, who will talk next week apparently, and he probably will come back to this. In his study with the study of Mesh and Shurian in 2015, they actually looked for the effect of ethnicity in the US context. And they, if I remember it correctly, they find that white people and Latino people are more, I hope I say it right, are more intended to take the vaccine than people from another ethnicity. So that's, and of course also in some of the studies which are more on Ebola, sometimes they take into account the neighborhood, or at least the region from where people are from, or the ethnic group that they are from. What we might be able to do, but we didn't do it so far, is, for example, to look for a municipality, because we know the municipalities of our respondents. We didn't do it so far. We were basically intending to link it with the rise of infections measured locally, because we also have distrust data we only showed here one wave because it's combined with vaccination data, but we have the trust data so far on 6 moments in time. And the first data set was even 220,000 respondents. So, well, of course, it decreased over time because it's a self-selected survey, so people answered themselves. So we could do that, and there is some, at least on the element of ethnicity, there's proof that it plays a role. If you look to this study of Mesh and Swirian, for example, but we haven't done it yet so far.
Thank you very much. Okay, then I am moving forward with a series of 2 questions as they are actually related from Hanan and first, and then Florentin. So please, Hanan.
Okay, thank you again for the very interesting presentation. I actually have 2 points that I'd like to make. First is I was wondering if there's been any effort to disentangle the role of government from sort of the other factors, and I think what might be good here is some kind of comparative view of vaccinations where the decision to take them is entirely private, and vaccinations where government is involved. And I was thinking, I mean, the best example would be, say, vaccinations that you take before you travel, and there it's not really, nobody's forcing you to do this, and not even going to be in the same country. And then there probably, you could really see very clearly what is of government and what is not. And another point is, I wonder if you thought about the question of which government do you trust? Because I guess the very important government is the U.S. government and the FDA, which all approvals kind of flow from. So I might trust my government, but if I don't trust the American government, I'm not going to take the vaccine. And again, I apologize for not having a video. I have a child sleeping on me currently, so that's why I'm not doing a video. So thank you.
Thank you. So I think we can follow up directly with Florentin, as I think it's yeah, a point that is somehow related. I don't know if the microphone is muted, but maybe I can just read the point made by Florentin Blanc, is a comment on the fact that vaccines in France are primarily administered privately, but trust is particularly low. Regardless of the mode of administration, trust in mandatory or recommended measures still depends on relationship to government. Yeah, so it's the question on whom is trusted. Is it the government? Is it the regulator? Okay, you can, if you wish, provide some reflections on this.
Okay, thank you very much for these interesting questions. I think the basic outcome, certainly from the results from Heidi Larsson, who runs this vaccination confidence project, which is probably one of the biggest projects, is that the trust in vaccines and vaccine-related factors is very much disease-related or vaccine-related, so it depends a bit. But the question whether a vaccine, if it's entirely private or it's mandated or recommended by government, brings in an interesting distinction. I think most research, what we are aware of, is basically those who are recommended by government or administered by government. So I have no knowledge of a study which actually compares the uptake for example, the vaccines before you travel to a tropical country versus those who are recommended, or even those who are basically mandated. Anyway, in general, the idea is, certainly when you look to the work of Heidi Larsson, is that making vaccines mandated or obliged is often would certainly not be a good strategy in terms of making it compulsory, because that in itself would induce some kind of adverse effect. But I think it would be, as a setup for a study, it would be extremely relevant to see what is actually the role of trust of government, to compare this. So this suggestion is very interesting. In terms of, do we actually measure trust in government, in the right governments? Of course, you point to a very good point that some medicines are actually agreed upon by other government than your own government, and also within government it's actually specific organizations. What we do have in our data is we have trust in the EU, in the federal government, in regional government and local government, and of course within the EU, the European Medicine Agency plays a very important role in the risk assessment for medicines in general, and also vaccinations. So for our own study, we could include it. In fact, basically the trust in the EU was included in previous version of the paper, and it loaded on the same factor, but then the comment came, but who is actually recommending the vaccine, which is often more the federal government or the national government or regional governments. But I think it's probably a good venue forward for research to disentangle who is actually trusted, in case the medicine is basically validated somewhere else. Is that government taken into account? Or basically the multi-actor setup of actors within government, the actual regulators checking upon the safety of medicines and vaccinations. And so far, most studies actually focus on government as such at an institutional level without breaking down much in different roles and different organizations.
Koen, may I add maybe something as well? What I was thinking of is that what we also stressed in the presentation is that it's important, the information source. So it really depends where the information from the vaccine is coming from, and that will probably influence people's attitude towards vaccination. And an interesting one is, for example, in Belgium, what we see now as the vaccine is further in its development, is that we see a lot of experts communicating and telling about, so in our case, the researchers at the University of Antwerp, of course, we see them in the news, in newspapers, telling us about the vaccine. So in that case, I think experts, again, will be an important source to be trusted, because if people won't trust the information they get now, that will determine their attitude towards the COVID vaccine as well. So it's merely a point of who does the information come from, I think, as well.
Great, thank you. I'm now taking the point raised by Sharona and by David Levi immediately afterwards, and then two related points raised by David Chinitz and Charles. So first, Sharona, and then David.
Thank you very much. First of all, it's really interesting. I just wanted to comment regarding the question of the difference between vaccines that are privately administrated and those who are not. Two things in the background. One is, I think it's important to understand that the trust is a continuous process. It doesn't stop by the decision of approving a drug or approving. There's a lot regarding what kind of reporting is being done afterwards. For example, are side effects reported? Are they being checked by the local regulations? So even if you have a vaccine that was approved by the FDA, your own regulator is the one that's supposed to be monitoring and seeing, you know, that okay, there was an approval. What is happening afterwards? After 5 years, after 10 years, or whatever. That was one point, and the other is the question of knowledge. Okay, because for example, I don't know how many people knew before the current pandemic that vaccines in Israel, for example, are approved by the FDA. I have no idea. I think I would suggest that most people had no idea that it's a foreign regulator that's approving them, and basically that's being trusted, and therefore the question of following up on Hanan's question, it's the right question. Who are we trusting and at what stage of the process?
Okay, David.
Are you waiting? You're waiting for me?
No, for me.
No.
I
meant David Levi for, sorry.
Yeah, sorry.
Yes, thank you very much, Martino. Thank you very much, Koen and Sophia. And also thank you for doing this book that I put on my background, which started the TiGRE project. It's called Trust and Regulation in Regulatory Regime. And this is the first work that put trust and regulation together. And actually started our project. So thank you, Koen, for that. And of course, Frederica. This is edited volume, by the way, and is available online. So the question I have, and it's really common, is how to balance trust and regulation when we study trust and regulation. Should we ask why people trust, or how much they trust, or is trust important? Or, and I would take it as the first side is more kind of on the personal level, or even social characteristic, demographic level, or maybe we should go from the other side, why government succeed or fail to create trust, or vaccination. And my feeling is that the literature so far, and it's not the point, it's not the problem of the literature, it's problem of the scholarly community, put the emphasis on trust and why people trust and so on, and not on government strategies. The regulation part is being marginalized in the discussion, the public policy side, I would say, even. So this is one. The other thing is how to study the issue, and I would look for theoretical debates. What is the theoretical debates that we want to come in and to solve or to expand and so on? And I'm missing the theoretical debate, and I'm missing it also when you put the kind of the emphasis on government or regulation, and also if you put why we trust, or is trust important. So who is wrong, who is right, who is stupid, who is I like the boxing arena, also in mostly in scholarly research, not in sport. I don't like boxing in sport, but in I think in research, it's the main strategy to move forward. That's all.
Martino, you're muted.
Yeah, sorry, I was just coming back to you, Koen and Sophie, if you want to give a reply to these 2 points.
Yeah, I think I think both comments point at elements that we should take into account more in the future, and shows the limitation of the current research, because indeed what is actually done now is that you ask respondents, are you inclined to take the vaccination? And then some other questions, do you trust government? But there's no relationship to what kind of stage we are in both the crisis or in the whole issuing of the vaccination. Yeah, certainly now with COVID-19, it's a clear example. We are compressing basically the way vaccines get accepted, tested, and approved. But they are still the same steps, but they are just shoved into one another. But people are actually thinking that or might think that some processes are skipped or some steps are skipped. So I think future studies should actually link to the stage of a crisis, the stage of the vaccine development and employment. Also looking more at the different roles that different actors play, like which was like, do they bring transparency into the system? Do they communicate well? Accept and go beyond this idea of who is improving the vaccination. And that actually links to, David, so you referred to the book and you referred also to the TiGRE project. Basically, what I think would be a good step forward in these studies on vaccination is actually to disentangle this regulatory system. Basically, the regulatory system does 2 things. On the one, or probably more, but on the one hand, it allows vaccines to be developed and tested and approved, but also it regulates how citizens should deal with them. They recommend things, or they mandate, they make things obligatory. They use different instruments to convince citizens, but it's still looked upon as a unitary factor. It's trusting government, while the TiGRE project is basically disentangling all the different actors in the regulatory regime and seeing how what the role is of politicians, of administrations, regulators at different levels, national level, EU level. And I think that would be, in terms of more the analytical approach, that would be probably an interesting step forward. In terms of the theoretical debate, I think this idea whether or not the question about how trust relates to regulation in relation to vaccines is actually depending on what you're looking at. If you're looking at the regulation, how to make a vaccine, how to test it, how to approve it, then this regulation will actually foster trust in, or if it's regulated well. So if the government regulates the private big pharma well in doing this process of testing and so on in a good way, that will help citizens to trust the safety of the vaccine and the effectiveness of the vaccine. If you're talking about regulation in the sense how citizens should apply the vaccination, that's another debate, and the relationship there is different. And probably it merits more the elaboration also as visible in some of the comments earlier, this distinction between privately administered and mandatory and recommended vaccines and how this is stimulated. But I think the what we are developing in TiGRE and also David, what you have developed is different views of seeing trust and regulation as competitive or as being mutually reinforcing or as supplementary is important because it's different, in my view, upon the kind of trust that, the kind of regulation that you're looking at, and probably also the kind of trust that you're looking at between which actors. And I think and it holds for our study also, we basically take a very large step backwards and only look at the trust of citizens in the system, while the whole trust relations within the system and between levels of government also plays a role. But I'm not sure if that is a good answer, because I have the feeling that I'm just wondering in my answers. Yeah.
Maybe we can further discuss some points also within the TiGRE project, because they are, of course, of general interest, but I would suggest not to go too much into the specificities related to the project, even though, of course, everyone is very welcome to have a look at our website and check out what we are doing. Now I will give the microphone to David Schinitz and Charles, who again have some related points. And then I think that I take the liberty of raising a point by myself. I think that we can go for another 10, 15 minutes, right? If everyone agrees. Okay.
So this is incredibly complex, and unrealistically, I want to hold everything constant except for pro-socialness. And I just want to point out that the tendency to free ride or not may be affected there are some people who will vaccinate no matter what, and partly because they know that they're contributing to herd immunity. But there may be some people who say, I'm willing to contribute to herd immunity if I know that others are contributing to herd immunity. And it could be that for any such individual, the more people that have vaccinated, instead of reducing the tendency, which would be a free rider, can actually increase the tendency because you don't feel that you're being a sucker. So I think this goes to the role of information provided by government as a regulatory tool, not mandating and not forcing, but trying to play off of people's perceptions by giving them a picture of what's happening, and maybe that would elicit more vaccination. And I referenced an article there that I think is relevant.
Charles, I don't know if you want to follow up.
Yes, thank you very much. I think my point is a little bit tangential to that, although it does involve the question of information and how it circulates and how it communicates, because I started to ask myself the question, well, why are some people hesitant and other people are more willing to be vaccinated? And I wondered whether this has to do with patterns of communication, so that there may be sort of bubbles, maybe very large bubbles of people who are hesitant, and all they do is talk to each other. You know, we're familiar with this kind of thing. And likewise, there may be large bubbles of people who are compliant and who are whether they're pro-social or whether they see it as their own personal advantage, more willing to be vaccinated. So the question there is, regardless of what government or experts are doing in conveying information, which then filters down into these bubbles and are either rejected or accepted, what do we know about the communication patterns amongst the hesitants that reinforces hesitancy or that erodes hesitancy maybe? And I wonder whether that shouldn't be part of the study as well. I come in being rather ignorant of this, but if I may take another point a bit further, I wanted to know, and I asked the question in the chat about what is known about how these things play out in Japan and other Asian societies. The reason I asked that is that I'm part of a research project which is looking at the responses to COVID-19, particularly testing and tracing, but also vaccination in Japan and the UK. We didn't start the project with that. We started it before anybody ever heard of COVID, but we've swerved to try and include that in a project which deals with how artificial intelligence and other new technologies relate to socio-cultural differences and so forth. And where you have a society, and here I don't mean to stereotype Japan or any other society, in which, let's say for the sake of argument, you get a much more deferential culture, how deference or other kinds of cultural attitudes which derive from historical or religious or other sorts of cultural beliefs and interpersonal etiquette of behavior, how that relates to people's willingness to comply, not just with the vaccination thing, but other things like social distancing, like wearing masks and so on. And the Japanese are very familiar with wearing masks, and that is said, subject to research, to be an important element in explaining what the patterns are of the response to COVID-19. So I put a question in pleading for any information or any research studies that people know about that, because we're interested in the socio-cultural dynamics of these things, including communication and including also things like relations between people and governments and experts and so forth. So I think that's all I could contribute to this just now, but thank you for letting me express that.
Right, so.
Oh, okay. I think both points are extremely relevant. The element of that pro-socialness is basically not enough. Yeah? You can indeed say I'm pro-social in nature, but I first want to know if I'm the only one who's actually contributing. So basically, I think it's a good idea, and it might help us to further develop the paper by, for example, combining or interacting the pro-social attitude and social trust, the trust that people have in other people, most other people. So just this element of generalized trust, because it plays both a role in this vaccination hesitancy. So I think it's the way we treat it now, it's a bit too simplistic. So we need a combination of factors there. But you also bring in this element of that, and it has been said already a few times, that transparency and the information providing role by government is crucial. And then there are indeed several studies which look at the ways to overcome vaccination hesitancy. And this kind of communication strategies are, of course, at the central stage of these vaccination hesitancy countermeasures. So to increase the knowledge about vaccination and the awareness, but also how other people treat it, so that you can create some kind of societal pressure for people to comply. I would agree that making vaccines mandated is certainly not the way to go, but communication and information provision is very important, but it should be very targeted, and it probably relates to the element of bubbles, which has been said by Charles. Yeah, this anti-vax is very much also fostered by social media, which actually reinforced themselves, yeah, the dynamics which reinforce themselves. And there are specific studies on that. I know that somebody or a group, a project run by the University of Leuven is looking at these kind of conspiracy theories and anti-vax theories, which are actually how these communication patterns in and out social media actually work. But so far it has not been linked to this broader issue of trust and regulation in relation to vaccines. But I would fully agree. And one of the elements that they say in terms of how to foster or to overcome vaccination hesitancy is indeed to make it very targeted. So to try to understand, to get into these groups, to get into these also societal subgroups which are reluctant to get vaccinated, and try to understand what is happening there and make it a very targeted communication campaign. So not across the board, but very targeted. And the role of healthcare professionals is crucial there, because at least we hope that these subgroups at least get in contact with healthcare professionals, which then can try to get a grasp on how these people think and how where these ideas come from, and then how they can be counterbalanced. On the sociocultural dynamics, and that's of course a broader question, we might think of sending you or putting in the chat, or maybe next week when we meet again, putting some studies in the chat, because it's specifically referring to Japan. I would have to have a look. But of course, the cultural patterns would play a role. If you just think of the very simple classification of Hofstede, with uncertainty avoidance and the power distance, which would raise the idea that, for example, when you are uncertainty avoidant, you might be more inclined to follow up regulations which give you a sense of security. Power distance is about the extent that you accept power differences. So in that sense, and it would probably be good to have some, just for example, with the material of Heidi Larsson, to see how these different cultural patterns which come from other studies, like the House et al. Study, to combine it with the data which comes from the Vaccination Confidence Project, which is also global, and to have a more refined answer on these kind of dynamics.
Fantastic. Thank you very much. So I had a kind of double question, but my main question was anticipated by your last reply. So that's good news actually. But the second one, it's on the fact that I'm not really sure about the causal relation, in the sense that whether it's a direct relation between trust and the intention to get vaccinated, it's a more indirect, mediated relation, or it's not something truly causal, but it's like a constitutive relation. So they go together, even though the influence, it's not a, cannot so easily disentangled. But of course, I think that it's entirely plausible that various operationalization of trust are positively associated with the intention to get vaccinated. It's intuitively plausible, of course. But my kind of question is, what happens in low trust societies? Because I'm not sure that the relation is so linear, in the sense that societies where trust in government is particularly low are also scoring low in trust in vaccinations. So the question is about this, so to say, the function, the type of function that you have in mind with respect to the relation between trust in government, trust in other actors, and the intention to get vaccinated, which is, I can imagine that it can be conceptualized as a form of solidarity after all, right? Or yeah, something like this.
Okay, okay. I think that's that's a very good question, and I think probably it's also because we, of course, put a lot of things together in one presentation, and basically, I think it's different from the level that you look at, and maybe we should have made the distinction more clear. But basically, we cover studies which look at trust in government in general, and then the trust in vaccination, or trust in government to deal with the crisis, and then vaccination. But there's also, of course, studies, for example, the study of Tom van der Meer, who is, or other studies who are more looking at trust in government to provide the correct information about vaccination, or trust in government to monitor the process well. So it depends a bit on what kind of operationalizations you have. Of course, if you take it as broad as, do you trust the government, or do you trust the government to handle the crisis well, then the relationship is indeed not a direct one. It's like a BAFTA model. You can have a relationship, but probably there are a lot of causal mechanisms at lower levels in between that. And the problem becomes bigger the more you focus on government in general, so not focusing on specific actors, and you focus on government in its general competence or general actions, or related to the handling of crisis more in general, rather than vaccination specific efforts. And probably if you would try to bring in all the knowledge together, we probably should make a clear distinction between these levels, because I do think when you are operationalizing it in terms of how trustworthy is the information of government about the vaccine and vaccination hesitancy, then of course your relationship becomes much closer, maybe not a fully direct relationship, but at least much closer. Bringing it all down to a form of solidarity, that's of course the way you, a lot of these, several of these studies would check for generalized trust, or would check for this kind of pro-social values, which are more like the intention. So the more, of course, you can control for these kind of elements, the more you avoid that the relationship that you're looking at is spurious and basically determined by some kind of underlying effect. But I think my main answer would be the indirectness of the relationship depends on how you actually, the scope of what you're looking at in terms of actors of government, so government in general or more focused, and the link with actual vaccine handling, communication, vaccine regulation. The more closer you are to that, the more direct I think the relationship becomes, although not one-to-one. I hope this is okay. Martino has an answer?
No, I have no answer.
No. Do you think it's? Yeah. Do you agree? Are you satisfied with the answer?
Yeah, I am. Of course, I'm.
That's my question.
Yeah, I'm absolutely satisfied with the answer and with the discussion in general. I think it has been truly stimulating. Just before concluding, let me remind you our next webinar on political orientation, trust in social and political institutions, and the adoption of protective behavior during the pandemic with Professor Gustavo Mesch. Next Thursday, November 26th, at 3 o'clock GMT. You have all the informations on our website, and I think that you will also receive a couple of reminders from the different mailing lists to which you are usually subscribing. So thanks to everyone, and to Koen and to Sophie in particular, again to David Levy for leading this webinar series, and thanks to all participants, much appreciated, and see you next time.